Hello.
Good evening, sir.
Hello.
Good evening, sir. कैसे हैं? How are you?
गुड इवनिंग सर। खोल लिया। कौन सी कहाँ से आवाज? यहाँ तो खुली हुई है।
अरे आगे सर आवाज आ रही है. Voice is fine.
फुल वॉल्यूम है।
हेलो. गुड इवनिंग सर. कैसे हैं? How are you?
गुड इवनिंग सर। हेलो पीयूष।
Sir, how are you?
आवाज क्यों नहीं आ रही? अच्छा,
Hello.
इसलिए नहीं आ रही क्योंकि हेलो।
Yes, sir.
हाँ, बोलिए।
Good evening. We are live.
गुड इवनिंग।
So let's start now. Right. So thank you all. We are live now with Dr. Prakash C. Malshe, sir, and as we know that weekly we are with him to understand on various aspects of clinical medicine, physiology, pathology. Uh, Several lectures will be coming up on pharmacology as well. So we are in the series of we are in middle of the series of pain. We have learned about certain aspects of pain in the last session. Hope you have seen the videos. Please subscribe Dr. Prakash C. Malshe sir YouTube channel. You have to just type the name which is there on the screen of Dr. Prakash C. Malshe. When you type this name on YouTube, you will get his channel. Just click on the subscribe button and see the videos. So pain already sir has uploaded couple of videos. सर ने वहाँ पर ऑलरेडी वीडियोस अपलोड कर दिए हैं, तो आप लोग प्लीज़ यूट्यूब चैनल पे जाएं और उसको देखें, अंडरस्टैंड करें एंड अकॉर्डिंगली द आइडिया इज़ कि हम इन सेशंस में क्वेरी स्कोर क्वेश्चंस को डिस्कस करते हैं. So we will be coming up with few questions right now, and we request all of you to start asking all the questions relevant to the topic pain management in your clinics, in your practices. You are having so many patients with so many different kind of pain. So maybe and today specifically we are focused on the abdominal pain. So today the focus will be on the abdominal pain. So please you can post your queries related only to abdominal pain. For other pain management we will have further sessions in coming week. So, Dr. Prakash C. Malshe, sir, I think right now he does not need any introduction on our platform as well. Still, as we have started this new streaming software and we are live right now simultaneously on Facebook, YouTube, on our website that is indianvadyas.com/webinar and on Periscope. So, for all the new doctors and students who are joining us today, he is one of the leading practitioner, physician, clinician of Uttarakhand, Haridwar. He is based out of Haridwar and leading एक practitioner है वहाँ के clinical medicine में सर का more than 3 decades का experience है and sir already has mentored thousands of medical students, predominantly Ayurveda BMS students in all these topics. So we are very much blessed and privileged and lucky to have Dr. Prakash C. Malse sir with us to understand and to develop more understanding on various aspects. So let's start quickly with this topic pain, and specifically as we mentioned today we will be discussing on the abdominal pain. So you can post your queries related to abdominal pain. Malse sir, your introductory remarks on this topic, that is abdominal pain.
Abdominal pain is a great challenge for every clinician because which pain will subside in a couple of tablets and which pain will turn into something disastrous. It is very difficult to judge at the beginning. But anyway, I have uploaded a lecture on pain in abdomen whereby I have tried to explain and to teach how to proceed with the diagnosis, how to approach a patient with pain in abdomen, what precautions to take, and how to exclude the dangerous possibilities of pancreatitis or a myocardial infarction in a case of pain in abdomen, and then what investigations need to perform. All this has been uploaded in a lecture, and I'll welcome if there are any questions from you or from your audience.
Thank you, sir. Thank you so much. So let's start with the first question of the day, and we request all of you to post your queries and your questions as far as abdominal pain is concerned. Sir, as we see in our clinics, patient आता है कि डॉक्टर साहब पेट में दर्द है. We know that it is an abdominal region. So अलग अलग regions है जहाँ पर वो हाथ लगा के बताता है कि मेरे को यहाँ पर दर्द है, मेरे को यहाँ पे दर्द है. And we have seen you are doing on your patients regularly the physical examination as far as the abdominal examination is concerned, palpitation of certain vital organs we have seen in your clinic regularly being done on various patients. So what is the most important thing to remember when approaching patient of pain in abdomen? So क्या हमें as a clinician ध्यान रखना चाहिए सर, इस बारे में थोड़ा बताएं.
Most important things are to remember are all the causes should be remembered. I mean, the cause of pain in abdomen can be inside the abdomen or outside the abdomen. There are several intra-abdominal structures which can cause the pain, like the liver, gallbladder, pancreas, stomach, intestines. In the women, there could be the ovaries causing the pain or the fallopian tubes. In both the sexes, there could be the ureters, bladder. Any organ can be the origin of pain, plus some extra abdominal structures like the spine could be at fault, because in the spine, when there is compression over the nerve roots, it leads to pain. At times, herpes zoster of the abdominal nerves will lead to abdominal pain, and many times it is due to the muscle cysticercosis. The muscles of the abdomen are at fault. They are harboring cysticercus cysts. And these are the various causes which one must always keep in mind. Apart from the abdominal and extra-abdominal structures, the cause for pain in abdomen could be metabolic. I mean, no organ is at fault, but if the blood sugar is very high, the patient is in diabetic ketoacidosis, there may be pain. At other times, the pain is due to adrenocortical insufficiency, and we have many of them in India. There are some more metabolic disorders which can cause pain in abdomen, like porphyria, but which are fortunately very rare. So if you just remember the diabetic ketoacidosis, uremia, and adrenocortical hypofunction, these are the metabolic causes. Many more times, the structural causes are not to be found. The cause is a functional one, and functional could be psychogenic. So these all various types of abdominal pains should be kept in mind, and accordingly we must proceed to take history and perform the clinical examination.
Right, sir. Thank you so much for this insight. And we are also seeing, and we, like as clinicians, are also getting many times the cases where many females are having pain after menopause. Like, so post-menopausal conditions are there. So how to identify and what are the indications as far as post-menopausal females are concerned for pain?
In post-menopausal women, the approach is slightly different, because their bones will suffer from osteoporosis, and therefore spinal causes, pains of the sacroiliac joints, sometimes pain of the hip joint, they are also referred to the abdomen, and great caution should be needed in diagnosing pain in abdomen in cases of menopausal women, because you must pay your attention to the skeleton as well, the spine, the hip joints, the sacroiliac joints. And secondly, it is somewhat easier to treat the menopausal women because for pain relief, you can give a combination of diclofenac and misoprostol, which is now available and which can be given to only postmenopausal women, not the women of childbearing age. Postmenopausal women, in addition, they will require supplementation of calcium and vitamin D. Some ladies were earlier given hormone replacement therapy, but then there were quite a number of side effects, and so hormone replacement therapy has been withdrawn. Uh, you can use alendronate to keep the bone strong. This is a group of drugs which reduces the calcium resorption from the bone, and there are various types of doses which you can use. There is a daily dose, there is a weekly dose, and there is a monthly dose. One can read the chapter of alendronate and one will know about all the details. These are for the bones, and we will discuss in detail about them when we discuss the subject of osteoporosis.
Right, sir. Thank you so much for this explanation. So there is one question from Dr. Kavita Agarwal. She is watching us live on YouTube, and she is asking, said, which sign or symptom can differentiate abdominal pain as organ related or physiological or metabological? So, but I think she wants to ask is whether it is a specific viscera or organ related pain, or it is maybe due to any other physiological or sometime muscular pain also we have seen are there, like for example in the lumbosacral region and all, and sometimes the renal calculi pain and the muscular or the pains from the vertebral column are need to be differentiated. So maybe you can throw some light on that aspect.
Yes, Piyush, if you are quite sure that it is an organ related pain, how can you be sure? Is that if it is a definite, if it bears a definite relationship with any of the organs. For example, the pain of stone in ureter, it will be there in the renal angle and then it will come forwards towards the left lumbar or right lumbar region, and then it will move towards the bladder side. So, if it goes like that, and if it is associated with hematuria, one can be pretty sure, even without an ultrasonography, that the pain is related with the renal stone. Because the combination of pain and hematuria and the peculiar site of the renal colic, they can make it identifiable. Secondly, if the pain is related with the fallopian tube, for example, there was a pregnancy for about 15 days or 20 days delay in the menstrual period, and then there is a sudden pain in one of the flanks, that is either the right lumbar or the left lumbar region, and then suddenly after a day or two the bleeding starts. So one can be pretty sure that one is dealing with a case of tubal pregnancy. However, most of these pains, which are organ related and which are metabolic, they need a little investigations on the laboratory side and on the radiological side. Because unless you examine the urine for sugar, you cannot detect its presence. Unless you detect high blood sugar, you cannot detect diabetes or diabetes related. That is what she means, probably metabological. And no great number of tests need to be performed. If you just test the urine for sugar and acetone, the diabetic ketoacidosis is either detected or ruled out. Then, if you go ahead with finding out the blood sugar with sodium and potassium, if the blood sugar is low, sodium is low and potassium is high, the diagnosis goes in favor of adrenocortical insufficiency, which can be confirmed by estimation of the plasma cortisol level. Most other organ-related pathologies can be found in the ultrasonography, because ultrasonography can detect presence of stones in the gallbladder, stone in the kidney, stone in the ureter or bladder, and it can determine the size of various organs like the liver, like kidney, spleen, etc. And it can detect the presence of enlargement of lymph nodes in the abdomen. It can detect the presence of ascites. and so many other things which can be detected, whether there are fibroids in the uterus, whether the uterus is gravid or not, whether the pregnancy is in the uterus or in the fallopian tube. Everything can be found out by a good ultrasonography. So ultrasonography is almost now a bedside investigation. Many clinicians have kept a machine with them, but of course then there are various licenses and registers and reporting involved, and therefore it is best left to the sonologist and not the clinician.
Right, sir. Thank you so much for this again detailed aspect like which has been discussed. Now the next point and next question is we need to differentiate sometimes like a common case of gas or gastritis or it is a common cause of pain in abdomen, and that can be one aspect. And related to this, sometimes we have seen this term and topic, that gas under diaphragm and all these aspects. So maybe you can just throw some light on these aspects as well.
Piyush, the term gas has got so many different meanings. As many, there are patients, as many meanings of the word gas. Because when the patient comes and says, Aji, Dr. Saab, gas ban jati hai. So it gives us no clue at all whatsoever as towards the cause of the pain in abdomen. Okay, then you need to ask the patient, what do you mean by gas? By gas, some people just mean belching. Other people mean flatulence. They pass flatus frequently, and that's what they call as the formation of gas. At other times, even headache is related with the gas formation. Vomiting is related with the gas formation by the patients, not by us. For us, there are different causes for headache. If headache is associated with vomiting, which occurs of an episodic nature and sudden onset, lasts for a day or maybe 2 days, such a headache, which is often unilateral and throbbing, we call it as migraine. But many people will relate it with the gas. By gas, several people mean a fullness of abdomen, which is probably related with nothing else but food. The food when they eat, when they start eating the puris or chapatis, they don't count. When the abdomen becomes full, they will stop. But the fullness will definitely increase when once the food passes down into the intestines and the intestines perceive the different chemicals. And if the food was fatty, the fullness will remain for at least 4 to 6 hours. If the food was light in composition, low in fat, more in fiber, the heaviness will not be there, and the fullness will be felt only for 1 to 1.5 hours after taking the food. But many people will say, no appetite, I don't feel like it, because they have eaten already in the lunch time so much that they don't feel like eating at the dinner time. And therefore, the problem of gas many times is a problem of overeating, and you just give a fast for half a day or a couple of days, and the gas, etc., will disappear. For many more people, there could be many more meaning of gas. There was one lady who was brought to me, and her husband used to say, if I give pressure to any of these sites here and here, and she belches, I don't know what it is, because there is no mention in the medicine books like any syndrome like this. But I have also seen a couple of patients, probably more than a couple, more than about 10 patients of this nature, that you give pressure to some part over the trunk and there is belching. It could be related with some autonomic reflex, which physiologists may not be aware but the reflex persists there. The reflex exists. And if you press over a part of the body, belching occurs. Why it occurs and in whom occurs, if anyone of you Vaidyas know it, a better explanation, you please come forward and give it to me. I didn't find it in my books.
Right, sir. And as far as Ayurveda is concerned, there are several aspects. So what we will do is, maybe we will plan a session in future, and there will be an interesting session in which you can figure out examples like this. And we have so many Ayurveda practitioners and Vaidyas with us, so we can arrange a dialogue in that scenario and in that context. The next question is from Dr. Hariom Singh. Sir, as we all know, NSAIDs are mainly used for treatment of pain, but how we should approach in case of pain due to ulcer? Because without endoscopy, it can't be confirmed.
Pain due to ulcer. Yes, uh, pain due to ulcer is an epigastric pain. It is severe. Yeah, if you just suspect peptic ulcer, because there is pain in epigastric region, the pain is related with food. Food aggravates it very often, and therefore, if you suspect that there is a peptic ulcer, please avoid all the NSAIDs. Don't give NSAID. I have uploaded a lecture on opioid analgesics. Pain 2 number of the lecture is pain 2, and in that I have described the several of opioid analgesics which are available to us, and tramadol is one of them, which will not cause the hyperacidity or aggravate ulcer symptoms. However, tramadol at times brings about vomiting, and it needs to be combined with some of the antiemetics like domperidone or ondansetron, or maybe perinom, metoclopramide. If you use tramadol, there is no risk of peptic ulcer getting aggravated. At other times, when there is actually no peptic ulcer, but you want to protect the person from peptic ulcer and you still want to give some analgesic, please check. You can use it in menopausal women, you can use it in men, but not in the women of childbearing age. The prostaglandin combination, which is available with diclofenac plus misoprostol. Such a combination is available, and you can use it in order to prevent peptic ulcers if there is no ulcer at present. But if you want to give analgesics for longer duration, in aged people, you need to give for longer duration because they suffer from osteoarthritis of the knees, and without analgesics, they cannot even walk. Some of them have sacroiliitis, some of them have lumbar spondylitis, and all these pains will require long-term treatment with painkillers. And so I recommend in menopausal women and elderly men a combination of diclofenac plus misoprostol.
Right, sir. And the next question, very relevant question from Dr. Kavita Agarwal, that when, as far as the patients coming with the complaint of abdominal pain, so when we need to refer or when we need to consider that this case is for the IPD management and hospitalization or any daycare or any that aspect is required, and which cases of abdominal pain we can manage in our OPD clinics.
If there is suspicion of peritonitis due to perforation, what I do in my clinic, I send the patient to an X-ray department, get an X-ray abdomen standing. If you go to my YouTube channel and watch the video on pain in abdomen, there is an X-ray that I have explained. Whenever the X-ray shows gas under the diaphragm, you were probably asking also what is gas under the diaphragm. When there is a perforation of the hollow organ system, like there is peptic ulcer perforation, or if there is a perforation of the intestines, or if there is a perforation of the appendix, all these things, all these organs, the whole GIT contains air. And when there is perforation, because of the contraction of the viscous, the peristaltic movements, the air escapes into the peritoneal cavity, and then it surrounds the liver, it surrounds the stomach, and since the diaphragm is there, when you make the patient stand up, the air goes up and the diaphragm checks it. So it gets collected under the diaphragm. And it is seen in the X-ray. I have given the X-ray in my video, and you please go to it and see the X-ray. And whenever there is suspicion that there is peritonitis, you can also do this. Get an X-ray abdomen in standing position, and if it shows presence of air under the diaphragm, you must straight away refer the patient to a surgeon, because this cannot be treated with medicines. Secondly, if there is severe infection, if there is suspicion of pancreatitis, if there is suspicion of acute appendicitis, all such patients should be treated in IPD, because if the symptoms, if the signs get aggravated, at any time they may need surgery, and therefore they should be under the care of an expert surgeon and kept inside the hospital, because they will require frequent injections, antiemetic, analgesic, and they will require intravenous fluid administration. And for all these reasons, they are best treated in the IPD. To re-enumerate, patients suspected to have peritonitis, suspected to have pancreatitis, appendicitis, and those who are having uncontrollable vomitings should be treated in patient department.
Right, sir. And there are a couple of questions. I think people who are watching us live directly on website, they have asked us directly. So the first question is, as far as abdominal pain is concerned, and if people with mostly the senior citizens or people with above 60-65 age groups are there, but additional aspects we need to take care, and we need to understand when we are having patients with senior age groups or people with 60-65 or more, as far as abdominal pain is concerned.
Patients above 60-65, they are susceptible to various other things as well. They are susceptible to clot formation, and ischemic pain inside the abdomen is quite common, which if it goes unnoticed, it can prove to be disastrous. They are also prone to bleeding from anywhere, because many of them are constantly taking some of the analgesics, and gastrointestinal bleeding is quite common. Therefore, these two things must be kept in mind: thrombosis and hemorrhage inside the gut or in the mesenteric vessel somewhere. And they should be watched for their pulse, blood pressure, blood volume, hemoglobin. If any of these things they appear to be falling, then a hemorrhage can be suspected. Uh, there was one more question from you. What was that?
Yes, and another question is, hello.
Yes, I can hear you.
Right. So another question is, if there is a case of intestinal obstruction, so how we can suspect that, or how we can in our clinic, be it a specific kind of a pain or any other symptom, as far as
Oh,
intestinal obstruction is
very,
concerned.
very, very important question. Whether the patient is passing gases or not, हवा पास हो रही है कि नहीं हो रही है. Secondly, motion हो रहा है कि नहीं हो रहा है. If the motion is totally stopped, if the passage of air, that is gas, that is flatus, is totally stopped, then you must suspect intestinal obstruction, which is of a total nature. But at times when the obstruction is in the upper intestine, the gases will still pass, because the lower intestinal passage is open, and the bacteria can produce gases by fermentation. And therefore, if at all the passage of gases will also stop in a couple of days, and the motion will also stop in a couple of days. If nothing is passing down, then you suspect a total GIT obstruction. Then, if you make the patient stand up and get an X-ray in standing position, X-ray abdomen standing, you get a particular finding of multiple fluid levels. I have not posted that X-ray, but please wait, and I will post this X-ray also, which shows multiple fluid levels in the abdomen, and which is an indication for intestinal obstruction.
Right, sir. And one more question is there from Dr. Ravindra. So, like, he's asking that in renal colic, some patients have very low blood pressure, or sometimes we have seen that they are going into shock and all. So, what to do then?
What to do? Wait for a full lecture on management of shock. In short, the shock could be of four varieties. There is a hypovolumic shock. If the blood volume is low, how do you know? The neck veins are flat, they are empty, all the veins are empty. And if at all you are in a position to check the central venous pressure by putting in a catheter inside, that is of course somewhat difficult. But then the CVP is also reduced. Then you have to supplement lot of fluid in order to make up for the fluid deficit by whatever reasons it has occurred there. And if it is a hypovolemic shock, you will correct it by just infusing intravenous fluid. But if the shock is of a different nature, for example, if there is something wrong with the heart, then the patient is in a cardiogenic shock, blood pressure is not recordable, then you need to give some cardiotonic drugs like in the drip. One needs to infuse dopamine, and this is best done in inside 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 an intensive care unit. If the patient is in shock, anyway, he requires IPD treatment, not OPD treatment. You need to give intravenous fluids or maybe some pressure agents like dopamine, which will stimulate the heart and make up the blood pressure. If it is a septic shock, you need to treat the sepsis. Bacterial infection needs a lot of antibiotics, and some steroids may be needed to be given to suppress the formation of all those cytokines which mediate the shock syndrome. So the treatment of shock is entirely a different chapter, Piyush. And the four types of shocks are there. Anaphylactic shock is probably the easiest to treat because you just give adrenaline and the anaphylactic shock disappears and the patient revives. If it is a hypovolemic shock, you need to infuse lot of intravenous fluid. In cardiogenic shock, you need to give cardiac stimulants, and in septic shock, the treatment depends upon your success in treating the infection, the sepsis, and also preventing the cytokine storm. So it is the most difficult of all is the septic shock, and you really don't know because of renal colic which shock occurs.
Right, and I think let's stick to the questions related to abdominal pain today, and let's wait for forthcoming lectures. There will be several lectures on several topics, so I request there are a couple of questions which are not related to pain. So please let's hold those questions for time being, and I request all of you to please post questions only related to pain or abdominal pain today. The next question is from Dr. Shivika sir. She wants to ask that as far as there is a criteria, and in clinical medicine and clinical diagnosis also we have learned this. I think she wants to understand between the pain which sometimes patient is coming with the complaint and the tenderness, like we are doing the physical examination and then patient is saying okay, in this area, when you like when we examine and they are experiencing, or when somebody is touching, then they are experiencing the pain. So as far as the abdominal region is concerned, how we can differentiate and how we can understand pain as well as the tenderness aspects, and which diseases or which possible clinical indications can be related to either or both as far as pain and tenderness is concerned.
Piyush, if it is a milder disease, then you don't get pain, but the tenderness is there. For example, someone comes with a small lump over here. If it is an erythema nodosum node or whatever node it is, so it may not be noticeable even by the patient. He just woke up, there was no pain, but when he touches that part, he feels that there is something which is causing pain on touching, so there is tenderness. So milder infections or inflammations will cause only tenderness. When the pathology increases, when the inflammation increases, then it causes pain even without touching. So pain is a greater degree of discomfort than tenderness. When we examine a patient and elicit tenderness, then it is in the abdomen, it is organ specific. If we palpate the liver, the patient takes in deep inspiration and then there is pain in the liver, it is a tenderness of liver. And tenderness could be found in hepatic amoebiasis and many more amoebic pathologies, many amoebic abscesses or other liver pathologies like hepatitis. Tenderness in other areas which may be related with the colon, which may be related with the small intestines, related with the lymph nodes, related with the uterus, ovary, fallopian tubes, there are different location, and like we have discussed, the McBurney's point is a point of tenderness in acute appendicitis. So when palpating the abdomen, the anatomy of the abdomen has to be kept in mind, and remember that tenderness is a milder pain, because if you detect tenderness, that means you are detecting early even without the patient complaining of pain at rest. If you don't treat, the pathology will increase, and the patient will start complaining of pain at rest even. And therefore, it is best to detect at a stage when there is only tenderness and no pain. And if there is tenderness, you need to give appropriate treatment for that particular organ.
Right, sir. Right. And the next question is from Dr. Kalyani. She is joining us on YouTube. So she just want to discuss one case. A female of around 45 years with fatty liver, grade 2, always pain in right epigastric and also pain in epigastric when lying on left side. It subsides on changing the side. What can be the diagnosis and what test we need to be like investigating?
Dr. Kalyani, the pain is most likely not related with the fatty liver, because as I have already discussed in one of my lectures, NAFLD, which is available on the YouTube, both in English and Hindi languages, NAFLD will not cause pain. Indeed, NAFLD is just a warning to the person that you have fatty liver, and in the future, if you don't take precautions, you are going to get hypercholesterolemia and all those associated problems with it, or you are going to turn into a diabetic. And therefore, fatty liver is not in fact a disease, it is a warning. With the pain is due to something else. And what thing else? In the liver, most commonly the pain occurs due to amoebic pathology. And if you do the total differential count, you will probably find an elevated polymorphonuclear count. And if it is so, just treat the patient with metronidazole for 10 days, and the patient will improve. The dose of metronidazole in an adult of average size, about 55 or 60 kg, is 400 mg TDS. If the patient weighs more, say 80 kg, then you need to give about 400 mg TDS of metronidazole, even up to 800 mg TDS of metronidazole. And the liver pathology, which is likely due to invasive amoebiasis, will improve and the pain will disappear. Sure.
Right, sir. The next question is from Dr. Kavita. So, how to differentiate, or maybe the differentiating factors between fatty liver and cirrhosis of liver as far as pain or any other symptom is concerned?
You
Maybe we
see,
can
there
discuss
is
right
one
now about pain.
fibroscan is available, which will detect the presence of fibrous tissue in the liver, and fatty liver is detectable at ultrasound. So, if the sonologist says it is a fatty liver, you believe it is a fatty liver. Then go ahead with the fibroscan so that you can learn about the amount of fibrous tissue present in the liver. And if the fibrous tissue increases, then the diagnosis of cirrhosis comes in. With cirrhosis, there are several features associated, like the portal venous pressure is increased. So, portal hypertension, what we know as, and portal hypertension leads to splenomegaly. There is formation of esophageal varices, which you can detect on esophagoscopy. There is formation of a caput medusae over the umbilicus, which is somewhat rare, but formation of piles is also quite common in cases of cirrhosis of liver. Then when the pathology increases, when the cirrhosis increases, there is development of ascites, and which is very obvious. With ascites, there is development of veins over the abdominal wall, and that you can see very clearly. At times, some spider nevi are also to be seen. I have uploaded a video of spider nevi. Please go and see on the YouTube what a spider nevus looks like. There is one central arteriole from which spread so many branches, fine branches, and they look like a flower. If you press in the middle with the head of a matchstick, in the middle the arteriole is compressed, the whole flower disappears, and when you release the pressure, the whole flower again appears of the blood capillaries. And so these are all the signs which one can see and make a diagnosis of cirrhosis of the liver. At the end stage of cirrhosis, the liver size is reduced, it is fibrosed, it becomes hard, and it is palpably hard inside the abdomen. There is formation of ascites, and all these signs should indicate towards the presence of cirrhosis of liver.
Right, sir. The next question is from Dr. Hariom Singh. He wants to ask that how to approach for management. I will not quote this as treatment, but it can be the management for terminal cancer. Pain in abdomen cases are concerned, which is already diagnosed. So maybe the patient is on palliative care. So I think treatment and all these aspects. Yeah.
Palliative treatment and opioid analgesics available to us is tramadol. There has been a plea from the doctors that the use of morphine should be allowed in such cases, and probably it is under consideration, because these patients, when they have pain, when we cannot cure the illness. We have to only provide comfort to the patient, and the uh, best comfort which is provided is by opioid analgesics. Morphine is a number one drug in the opioid analgesics, which is used in cancer patients which have gone beyond a particular stage. And you can hear my lecture of Pain 2 of that series, which is all regarding the opioid analgesics. Uh, there is the pharmacology of morphine, which you can study and wait till the morphine is made available to us for clinical use. Till such time, you can use tramadol, either tablet or injection, and that will relieve the pain to quite some extent. You can also use inhalation and pain prevented. Was there an interruption in between?
Yes, sir. Yes, sir. So I think questions are pouring in.
Archana Kevalani.
But yes, we can have couple of questions, although it's not related to abdominal pain. But yes, she wants to ask regarding pain only. That I think it's a very common finding that in chikungunya, post chikungunya.
चिकुनगुनिया का बुखार उतर जाने के बाद
हाँ,
और
क्वेश्चन है
जोड़ों
कि
का दर्द और मांसपेशियों का दर्द क्या लिखा है आगे?
दर्द मतलब रहता है, वो नहीं जाता है, तो क्या करना चाहिए?
मांसपेशियों का दर्द बता रही हो, क्या करना चाहिए? मांसपेशियों का दर्द क्या लिखा है आगे?
मतलब she wants to say that if there is pain in joints and muscular pain is there after chikungunya infection, so how to take it forward?
इसमें यह है कि इसे कहते ही है पोस्ट चिकुनगुनिया पॉलीआर्थराइटिस वास्कुलाइटिस सिंड्रोम। और सबसे बढ़िया बात यह है कि ये 1 या 2 महीने का ट्रीटमेंट की जरूरत इसमें रहेगी। ऑल्दो जैसे ही ट्रीटमेंट हम शुरू करते हैं, दर्द वर्द तो ठीक हो जाता है। The treatment is very similar to the treatment of rheumatoid arthritis, and I will just chalk out. You need to give, considering an adult of about 60 kg, you need to give prednisolone 20 mg on alternate days. Give 1 HCQS, hydroxychloroquine sulfate 200 mg every night with milk, and give 1 tablet of methotrexate, that is Folitrax 15 mg once in a week, combined with vitamin D and calcium. Vitamin D 60,000 unit once a week, and a tablet of calcium and a tablet of multivitamin. These all things will do the trick. Once you start the glucocorticoid, that is prednisolone 20 mg alternate days, the patient will get immediate relief in the pain and the swelling as well. And if you continue it for about 10 days, the swelling is completely gone. But if you stop the treatment there, the swelling may reappear, and therefore the treatment should be continued for about 2 months in post-chikungunya cases. So I guess, Dr. Archana, that satisfies your question.
So Dr. Kavita is asking that pain specifically related to urine infection. So maybe we can go down to the lower abdomen or maybe some kind of a pubic region pain as far as urine infection related pain is concerned. So maybe sir, you can throw some light on that.
Pain of urinary infection can occur in the bladder region, in the ureter region, or in the renal pelvis region, anywhere. Because if there is pyelonephritis, the pain is almost indistinguishable from the pain of renal stone. And therefore, whenever there is a severe pain, the site of the pain, if the patient tells you like this, where my thumb is there, if there is a pain in the renal angle, and then it comes down in front and goes down to the hypogastric, that is the bladder region. Why? Indeed, whenever there is a reduced fluid intake, then also such pains can occur, which can be relieved. And this thing occurs quite commonly in the summer season when patients usually don't cope up with the demand. They cannot drink enough water as the body requires. And when the urine becomes very concentrated, then also such pains occur. So all these three types of pain, they are quite similar. Pain of dehydration, pain of urine infection, and pain of renal stone. They can occur in the bladder region, in the ureteric region, or in the region of the renal pelvis. They are quite constant and severe, and they require urgent attention. Such pains are relieved by an injection of NSAID, maybe diclofenac or piroxicam injection, whatever injection you can give.
Right, sir. I think today many doctors are attending. We are getting very good viewership, and so questions are pouring in. And hope you have some more time with us today because lots of questions are coming up. And I request all of you to do subscribe YouTube channel of Dr. Prakash C. Malse sir, so that many of your questions can be answered in the videos. I again clarify these sessions are query discussion sessions. The exact lecture, the entire lecture sir is uploading in a form of a video on his YouTube channel. तो मेरी आप सबसे रिक्वेस्ट है कि पूरा टॉपिक समझने के लिए आप सर का यूट्यूब चैनल सब्सक्राइब करें और वहां पर सर के वीडियोस को देखें. यहाँ पर वी आर जस्ट डिस्कसिंग द queries after you have seen those videos. So again, I clarify you to get a pulse and to get a feel of these sessions. Do see the videos. Next question is from Dr. Chavla, Dr. Kailash Chavla, that sometimes patients are coming with both the renal calculus issues and cholelithiasis as well. So how to deal with that situation in terms of clinical aspects are concerned?
In such a situation, NSAID must be combined with an anticholinergic drug. If you want, and if the patient is amenable to treatment with tablets, I mean, if there is no vomiting and if he can wait till the effect of tablet comes, then the tablets of choice are a combination of NSAID plus a anticholinergic drug, which will contain something antispasmodic, like a dicyclomine or camilofin. So there are so many combinations available in a tablet which will contain one NSAID and one smooth muscle relaxing agent like dicyclomine or camilofin. But if you need to give injection, the injection also needs to be a combination of NSAID plus anticholinergic. If you don't have a combination, give them separately. The most potent anticholinergic agent is injection atropine. Other choices are injection. We used to have Buscopan earlier, which is now available as Buscogast and Hyoscymex. Two different companies came out with two different names. So you can use one of these in combination with an NSAID, and you will get relief in both the pains simultaneously. Then there is time to focus which one needs urgent attention. And if the renal stone is small, that is smaller than about 10 mm, it does not need to get operated. But if the gallstone is of any size, it will not dissolve with any drug, or it will not come out also. And therefore, whenever there is a gallstone and which is causing recurrent pain, it needs to be operated. Uh, Nowadays, the preferred mode of operation is the laparoscopic.
Right, sir. And Dr. Rajan is asking regarding abdominal examination to differentiate flatulence. I think we have already discussed this, Dr. Rajan. Maybe you have joined a bit late, so you can rewind the session and please see the video. Dr. Jitendra Pandey is asking regarding the diagnosis of intestinal ischemia. So again, maybe if you feel, sir, it is relevant, or maybe if you are taking this topic in the future sessions, so maybe we can discuss this intestinal ischemia in that those sessions. So we'll be talking on that, sir, in future sessions about intestinal ischemia.
Yeah, yeah. Please keep in the wish list.
Sure, sir. Sure. Then I think most of the questions we have taken. Dr. Neeraj Kumar Gupta, he's one of my senior. So he's asking regarding splenomegaly. I think splenomegaly is one question which we can take right now. As far as abdominal pain in case of splenomegaly is concerned, so what exactly the aspects you need to understand? And he's also saying that if it is related with diabetes and fatty liver also, so maybe you can just give us some insight on cases related to the spleen, because we have already discussed with you regarding the fatty liver and renal and other aspects. But yes, splenomegaly, sir, just give us some brief aspects
Yes,
on that.
Pierce splenomegaly is not a normal feature of fatty liver disease, and it is also not a feature of diabetes. So there should be some other cause of the splenomegaly. There are so many causes of splenomegaly like malaria, kala azar, hemolytic anemia, and leukemia, just to enumerate a few. If there is portal hypertension, then probably you can say that it is related with the fatty liver, and therefore it is advisable when the fatty liver person passes through various stages. One passes through the stage of NASH, steatohepatitis, as we call it, non-alcoholic steatohepatitis, and then gradually the process of fibrosis sets in, which you can detect through a fibroscan. And if at all there is increased portal venous pressure, that is portal hypertension is there, then you can explain the presence of splenomegaly because of the liver disease. Otherwise, you should try to find out some other cause, the way I enumerated: malaria, kala azar, hemolytic anemia, leukemia. All these things first need to be ruled out before making a diagnosis of cirrhosis of liver.
Right, and I think we can take the final question of the day, because already we have like covered an hour discussing all these aspects, and otherwise you can just post your questions further. I suggest you to post questions on the YouTube channel of Dr. Malse sir, on the videos comment section of the YouTube videos, so that it will be convenient and easy for sir to answer, because he is personally supervising his own YouTube channel. So my request to you is, after these sessions on our platform, still you have any unanswered queries and questions, you can directly ask Dr. Malse sir on his YouTube channel. You can post on the relevant video, and as per my understanding, he is personally supervising all the videos and all the questions, and he will definitely answer you there. So the
And Piyush,
last
there
question.
are two very good videos that I have uploaded about pain in abdomen, one in English and one in Hindi. I think I should answer the question put forth by Dr. Kavita Agrawal. In post-menopausal women, there are frequent urinary, yes, there are frequent urinary infections. What precautionary measures to be taken? Alkaline mixture for several weeks is, yes, it is safe. If they are taking alkaline mixture for several weeks, it is safe. Number two, there is a tablet available, Cranmed, which contains extract of cranberry, which is said to be good for the urinary infection. And plus, there is a sugar, D-mannose. D-mannose is such a sugar which will not elevate your blood sugar level. I mean, it does not increase blood glucose. It does not get digested. It does not get metabolized in the body, we should say, and it is excreted in the urine unaltered. So D-mannose, and when it gets excreted in the urine, it binds with the flagella of the bacteria, and the bacteria are forced to flow down and get out of the body in the urine. and therefore such preparations are quite safe to be taken for any length of time. Maybe an alkaline diuretic, or maybe a tablet containing D-mannose and cranberry extract that you can use uh, to prevent UTI in post-menopausal women. Plus, of course, they must be given instruction on drinking lot of water, and particularly in the morning, it is best to drink at least 3 to 4 glasses of water on waking, and so that in the morning hours you pass urine so many times, and later on you feel quite light inside, and any bacteria which are trying to settle down in the urinary tract, they are just washed away. So drinking lot of water is the first thing one should do, and if that doesn't in itself suffice, then these two things are quite safe: alkaline diuretic and combinations of cranberry extract and D-mannose.
Yes, so we have also seen in our practice, and predominantly we are practicing Ayurveda. However, cranberry is a very effective, I can say, berry, as sir mentioned about the extract. In fact, we have seen many people are taking cranberry juice or cranberries also, getting very much relieved. In my personal experience, I have seen few cases, along with whatever that standard treatment we have given them. If they are using cranberry regularly, so this UTI issue is very much resolved. Quickly, sir, we can just touch upon one or two more questions if you have 5 more minutes. So, Dr. Siddhi is asking how to manage ascites, which develops as a result of CKD, that is chronic kidney disease.
uh, the management of ascites is also a part of management of edema, you can say, because there is a fluid over accumulation in the body which accumulates in the form of edema as well as ascites as well as pleural effusion. And if you just remove the fluid using diuretics, that is the mainstay of treatment for removing fluid. You need to use diuretics, and the strongest diuretic presently available with us is the furosemide. You can use tablet furosemide and injectable furosemide in increasing doses as the patient may require it. And also remember that furosemide also causes sodium potassium loss, and therefore the electrolyte estimations also should be carried out. A usual dose of tablet furosemide would be 40 mg per day, but when the blood urea, serum creatinine, they are increased, the kidney becomes less responsive, and you need to increase the dose from 40 to maybe 80 mg or 160 mg or 200 mg, because the medicine furosemide has a quite wide range which you can use depending upon the situation. If the kidney is not responding to a 40 mg dose, you can increase it to 80, then watch again. And if you need to increase the dose further, you can increase the dose further as well. But if you see that the kidney is not responding well, then it is best to consult a nephrologist. Because to remove the extra fluid, if the kidney is not not responding to our treatment, then dialysis is one answer. Dialysis can remove any amount of extra fluid which is present in the body.
Right, sir. Thank you so much. And last question of the day, finally, as we are talking about abdominal pain, and Dr. Joshi wants to ask that there are recurrent abdominal cramps. We'll be taking the management part later on, sir, or today, like also we can just have some discussion. So he's asking any safe treatment or injection or any quick remedy for recurrent abdominal cramps.
You see, injection diclofenac is quite safe as a pain relieving agent, but one must give it in a dose form that is 1 mg per kg of body weight. The injection comes in 75 mg, but so many of our patients are underweight. They are weighing only about 40 kg or even 37 kg, and which is quite half of 75. And therefore, everybody cannot be given a full ampoule. There is 75 mg in 1 ml. You need not give the full 1 ml dose to everyone. You need to reduce it to 0.7 ml or 0.6 ml according to the body weight. You consider that the full injection is for 75 kg. So it is quite safe. And if you need to give only once in a while, say recurrent means probably it recurs every fourth day or third day. So if you give one injection every third or fourth day, it's quite safe.
Right, sir. Thank you so much for your time again, and we request all of you to do subscribe, our Facebook page. Please subscribe YouTube channel of Dr. Prakash C. Malse, sir. You can subscribe our YouTube channel as well. We will be coming up with more and more sessions like this. Sir, you can just throw out quickly on the next week session and the forthcoming videos which you will be uploading in this week so that doctors can watch that and attend your next week session accordingly.
I will be uploading lectures on chest pain now. Although the lectures on pain in abdomen also have not been watched by many of your participants, so I will request them to watch these videos about pain in abdomen, and we will consider questions regarding both pain in abdomen as well as pain in chest in the next class.
Right. So I think what we will do is, for all of your convenience, we will upload the links of those videos also. And I request all of you to follow the YouTube channel. Again, I request all of you to follow the YouTube channel of Dr. Prakash Malse, sir. We will also upload the links of these videos in the comment box of the today's session also, so that you can just click and watch those videos. And please do watch and keep following the videos being uploaded by Dr. Malse, sir, so that all of us can be more focused and more productive in terms of our discussions of these weekly sessions are concerned. So next week, as Dr. Malse, sir mentioned, we will be focused on the chest pain. However, we can take some questions on the abdominal pain as well, if you can maybe just see all the videos accordingly. Thank you so much for joining us today. Have a nice festival weekend in advance. Happy Dashmi, happy Dashara to all of you. And with Malse sir, we aim that we are able to kill the evil of, I can say, less knowledge, or maybe sometime wrong knowledge within us. And the path should be enlightened, and there should be always a correct, specific knowledge. Under the guidance of Dr. Malse sir, we are heading towards that, so that in our clinic we can manage all the patients more effectively. Thank you so much, sir, again for your time. Happy, in fact, Vijay Dashmi to you as well in advance. And please keep supporting us. Please keep guiding us with your knowledge. We are very much privileged and lucky to have you, sir, with us.
Thank you. Thank you, Piyush.
Thank you, sir. Right. So, Malse sir has left for the day. Quickly, I just want to pitch couple of information here for all of you. There is very important webinar on medical cannabis coming up next week. We have already uploaded the information, so you can just register for that. It will be one of the largest and biggest webinar on medical cannabis. In fact, the first one to be done. We are targeting and aiming to have a very good strength of people attending that as a panelist as well as a participant. So please register for that if you have not done till now. It will be live on 28th of October, 11 a.m. to 1:30 p.m. In the afternoon. You can check the information that is available on our Facebook page. And if you have not registered on our website, please do. We are right now on the first page of Google of around 10 cities, and all the doctors who are there on the first page with us are getting very good response in terms of leads, patients, and footfall is concerned. And we will be coming up many more sessions, and we are also planning to launch some new initiatives. Maybe next week we will be coming up with that information as well. So please keep on supporting us. We are very much encouraged to see all of your support. Hope we are making sense to you. Uh, our aim is to uplift the entire fraternity with whatever the best possible tools available. And also, we have requested all of you to share your feedback. We have uploaded the link. Kindly click on the link and share your feedback, which help us to take it forward. Any learnings, do let us know. Any shortcomings, do let us know. And if you really like the session, please share your feedback on that link. Thank you so much. Have a great weekend.